Hello, everybody. I'm going to convene us. Thank you all for joining us. For those who I don't know, my name is Sandro Galea, and I have the great privilege of serving as Dean of the Boston University School of Public Health that is putting on this symposium. This symposium is called Stopping Suicide, a Population Health Approach. It is a virtual symposium held in 3 parts, and this is the second part. We had a terrific first panel last week, and this part of the panel is the keynotes, where we are very fortunate to have 2 excellent keynotes. Before I introduce the keynoters, I'd like to thank the group that has made this possible, particularly Professors Carol Dolan, Jamie Gradis, Sarah Lipson, and Julia Rafeman, who are the brain trust behind this. And in particular, also would like to thank the staff who made this possible, Meredith Brown, Alicia Noel in particular. Thank you to everybody. And I would like to thank all of you. I realize that there are a lot of pulls on people's time, and we are very grateful to all of you who join us for these conversations. This series of panels aims to address the persistent and daunting public health challenge of suicide prevention. And our goal really has been to bring the top experts in the world to discuss causes and potential ways to prevent suicide to improve the health of populations. As we note in our, in our material promoting this event, if you are thinking about suicide or worried about a friend or loved one or would like emotional support, the Lifeline Network is available 24 hours a day, 7 days a week across the United States. And you will see the contact details in the chat box. I'm truly excited about our speakers today. We're going to hear from 2 keynote speakers, from Dr. Devorah Castell and Dr. Josh Gordon. Dr. Castell is the director of the World Health Organization Department of Mental Health and Substance Abuse, and Dr. Josh Gordon is director of the National Institute of Mental Health in the United States. Each of the speakers will talk for about 30 to 40 minutes, and then we'll have time for about 15 minutes of Q&A, which I will moderate. We're going to start with Dr. Castell. Dr. Castell recorded her talk and sent it ahead of time because she's been pulled into a meeting with the Director General of the WHO. We are hoping that she'll be able to come for the Q&A in half an hour. If not, her deputy will be joining us for the Q&A. But first, Dr. Castell, Director of the WHO Department of Mental Health and Substance Abuse, in a recorded video.
Hello, good afternoon, and thank you for the opportunity of having me today with you. I'm recording this earlier to make sure that you get it properly and on time. One never knows with the connectivity these days. So thank you, Dr. Galea, for inviting me, and I hope for the next opportunity to be there in person with you. I'm Devorah Castell. I'm the director of the Department of Mental Health and Substance Use at the World Health Organization. And today I'm here to talk about suicide prevention. And of course, the specifics of today are a population health approach to prevent suicide from the World Health Organization perspective. When preparing this presentation, I couldn't avoid recalling the first couple of cases of suicide that I remember. The first one was a personal connection, somebody I knew from college. And the second one was in the context of a clinical practice. And I'm sure that we, many of us have that in mind, because no matter how many years behind the issue happened, we can't forget the tragically death of suicide. It is something that for the individual, of course, for the family, for the community, for the context, for practitioners, it leaves a sign. And so how do we go from there to the work that we do at the WHO? This is what I will try to take you through. A bit of history here. The beginning of the first document that highlights the issue of suicide is a UN document published in 1996. It's Prevention of Suicide, Guidelines for the Formulation and Implementation of National Strategies. Is one of the first ones, as I said, from a global perspective, multilateral agency. Of course, there were previous ones developed at country level, including the US, but this was the first one of this kind. And it already emphasized some of the issues that are going to be further developed later on and that are valid today. So in 2012, after many years of having used research knowledge and understanding of suicidal behavior, a second document comes out from the UN that is from WHO, sorry, that is following the UN one, and is on public health action for the prevention of suicide, a framework. And that identifies a component and clear steps for developing a comprehensive national suicide prevention strategy. And then in 2014, WHO published its first ever World Health Prevention Report, Preventing Suicide, a Global Imperative. And there is highlighted the key components, the key also knowledge that at the time we had on suicide prevention, and also presenting data from all countries with all the modeling that at the time was done to summarize the current situation at global level. Then WHO Director General, Dr. Margaret Chan, said that this was really a call for action for countries to employ a multi-sectoral approach that addresses suicide in a comprehensive manner and that will bring together the different stakeholders, which is based in current resources and context. So for a neglected public health issues such as suicide prevention, this was a bit of a momentum, right? International level, the situation was looking promising with all this attention around the topic. At the time of the UN report, there was only one country with a national prevention, suicide prevention strategy, that was Finland. Right now there are 38 countries with national strategies, and we will see more about that later. So, suicide becoming a global priority, we have the UN Sustainable Development Goals, SDGs, and I'm sure many of you are familiar with that. There is a target there that heads of states agreed was a priority and to be included in these SDGs, and the indicator is, the target is about the reduction of NCDs and mental health and well-being, and but the indicator selected for the context of mental health has been suicide mortality rates. Now, during the definition of the WHO General Program of Work 2019-2023, defined by our current Director General, Dr. Tedros, again, suicide was selected as one of the 40-something indicators that are considered as accelerators for the achievement of the goals of this program of work. And this is reduce suicide mortality rate by 15%. And then last but not least, in 2013, WHO member states agreed that mental health was a priority and that a mental health action plan was needed. Last year, it was decided to extend it to 2030 precisely to align it with the SDGs. And there are 4 objectives. In Objective 4, that is about implementing strategies for promotion and prevention in mental health. Again, suicide and the rates of suicide in countries to be reduced by 1/3 by 2030, selected as one of the very few indicators that are part of the plan. So we could say that from a global political will, the visibility and the attention has been generated. That what we need to find out is what is the accountability in that, in this context. Are all these goals followed by a clear accountability and a clear way to measure and to see progress? Let's have a look at the situation, because you will see that unfortunately, no, the big global political will is not followed by countries implementing what they have committed to do. at least not at the pace we would like to see. What we will see, I assume that many of you are from the US, so you will, in the audience right now, so we will have a look at the situation at global level. We work with 6 regions within WHO, and in the 6 years between 2010 and 2016 that you see in the table, the global age standardized suicide rate decreased by 9.8, but the decrease is only in 5 regions of the world. The decreases range from almost 20% in the Western Pacific region to 4% in the Southeast Asia region. But I said that earlier, we have 6 regions in WHO, and 1 region has increased, and this is the region of the Americas, with an increase in 6% in the same period. So even with the overall slight decrease in the estimated suicide rates, we still need to do something to see that the world entirely is decreasing as requested or decided with these global goals. We will go later on to see a bit the situation about data and how the accuracy or not accuracy, availability or not availability of data will have an impact in what are we talking about when we talk about real data. We know that data is a core component in suicide prevention, and will tell us where action is needed, what for, and who needs to be supported where. But this is a challenge still, and we will see a bit more about it soon. So I hope that with this information, a few slides showing this situation, you will be able to compare with the situation that you know pretty well in the US, and some of the presenters last week went through some of these very recently released data from CDC, for example. So what we see is that, again, suicide remains a global public health issue, and given the data we have just seen, it remains a neglected, actually, global public health issue. Around the world, almost 800,000 people lose their life to suicide each year, and this means that 1 person dies by suicide every 40 seconds. We keep repeating this number, and it is always shocking to consider, to really think about it. 1 person dies by suicide every 40 seconds. Suicide is then among the top 20 leading causes of death worldwide, and there are more deaths due to suicide than to malaria, breast cancer, or war, and homicide. And I'm saying this because any of the topics I mentioned earlier receive more attention and then also more resources than what suicide does. And this is something that we need to consider and wonder why, right? Because also, apart from the, we know that from every person who dies by suicide, there are at least 20% that have attempted suicide. So that means millions of people that may need some kind of support, but also it means that for every person, many around that person have been affected, right, within the family and the community. Suicide occurs in all corners of the world, and there is a preconception that suicide is more prevalent in high-income countries, but we know that 79% of suicides are in low and middle-income countries. And you can see in the slide the variation between one region and the other, but in terms of the income group. But it is pretty much everywhere, as I say. Then for both sexes, the rates are highest in the Southeastern Asia and European regions. Males are highest in the European region, and females, the highest rates are in the Southeast region. And globally, the age standardized suicide rate was 1.8 times higher in males than in females. Suicide occurs across the lifespan, but after road injury, suicide is the second leading cause of death in young people aged 15 to 29 years old for both sexes. And this is extremely important and something that we have not been able to generate the attention it deserves so far. Suicide is the second leading cause of death in 15 to 19 years old. In girls after maternal conditions, and is the third leading cause of death in males, 15 to 19. Also, again, 90% of adolescents who died by suicide are from low and middle income countries. And most or half 50%, 52% of global suicide occur before the age of 45 years. And we need to think what is happening, why it is that young people are losing their lives even before they have the chance to see what it is about. And then also in older adults is an issue that is frequently neglected. So we need to again make sure that data is available so that even with high-level documentation and high-level global targets and high-level prioritization of suicide, data is not giving us hope, is not preliminary, that is not showing us that we are doing any better. So the challenges are that I said earlier that 38 countries have a dedicated national suicide prevention strategy, but it's good when we compare with the first only country in 1996. But 38 countries is just 20% of the countries from the World Health Organization. We have 194 countries, so it's really small a number. And we still advocate for countries to take action in preventing suicide from a national perspective, because it ensures government and different stakeholders to be committed around this issue. It should work in facilitating the coordination, placing the topic high in the political agenda, and therefore ensuring resources, financial, human, and also making sure that then action is set following some clear criteria and understanding. And something that we didn't say so far is that the stigma related to suicide could usually it is usually a barrier, but it could be overcome maybe by this big buy-in from a number of actors in the political agenda. We have seen, and particularly in the US, right, the big fights with the HIV and the possibilities that brings when the advocacy around a topic and the right of people at the time with HIV to receive care definitely produced a change. So it's something similar we still need to see around suicide, right? We don't want people to die by suicide, to make sure that the advocacy and the resources are there. So we need to find other strategies that hopefully we are on our way. We are talking about the challenges, and it is present in many research preliminary studies and the media, the impact of suicide, of COVID-19 on suicide and self-harm. And we know for us it's too early to tell this impact, because again, national statistics of suicide will not be available until early next year probably. And we hope that self-harm data from the few existing national self-harm registries could become sooner, but maybe not enough or not from many countries. We know that some of the COVID-19 consequences in society and economical situation could become risk factors for suicide. On one hand, the isolation in many cases, but also then the unemployment and economical turmoil in general. We know it is related to, or in other cases in the past has been related to suicide. And so we hope for action to take place before any of these starts happening to prevent suicide as possible. We just published this book that you see there, this publication, sorry, that you see there, and it's a rapid assessment on the impact of COVID-19 on mental, neurological, and substance use services. And we noted that 24% of countries reported a disruption to the suicide prevention program. So this is a time to pay attention to that and see how we make sure that services are available for those who need that. Mortality statistics, including causes of death, are the foundation of public health planning, monitoring, and evaluation of intervention. And only 80 countries have good quality vital registration data on suicide. 44 are high-income countries, and that represents 96% of the all estimated suicides in high-income countries, while 37 are low and middle-income countries, and that represents only 20% of all estimated suicide in low and middle-income countries. So again, the problem of poor quality mortality data is very important. It's not exclusive for suicide, but once again, stigma here plays a big role in terms of the complexity of classification, but also the need in many cases to hide the reason of mortality being suicide, and it is other reasons are being given to again to avoid legal consequences, or in some cases religious issues, in other cases just the complexity attached to this recording system for suicide. So the other issue is that monitoring suicide attempts provides also important information for suicide prevention, but this is again not so frequently seen. We do then have a proposal, and this is what we call live life. Live life. And this means that less means, sorry, I got a bit confused now. We are talking about 4 evidence-based interventions here, and the 4 are listed there. Less means, which means restricting access to means of suicide in any context. For example, banning highly hazardous pesticides in many countries, we will see soon. The second one is the interaction with media, is responsible reporting by the media to ensure that reporting is properly done. The third one is school-based intervention for building social emotional life skills in young people. And the fourth one is early identification, assessment, management, and follow-up of people with suicidal behavior in healthcare settings and beyond. We know that suicide prevention is not exclusively a health issue, but we believe that the health sector could lead this work in coordinating with others at the community level and other sectors to ensure that programs are in place and properly implemented. So when we talk about the control, means control, you see there a couple of publications, and we talk about pesticides, hanging, firearms, that are among the most common, depending on the region, of course. And pesticides is the main one, so that's why our emphasis has been on pesticides control. And we are promoting banning highly hazardous pesticides based on some research done, and there are some studies in Sri Lanka and Korea confirming that. Other countries are introducing these pesticide bans. And of course that will change, and I'm sure in the US you are very familiar with other programs that are more relevant to the country, in this case gun control, but it depends on the main mean that is used nationally or locally, and the different demographic groups, and it can change over time. So what is important is that we follow up and intervene with the specific means that are needed to control in each case. In terms of interaction with the media, you see also there are a couple of publications, and we are aware of the negative and the positive impact of media reporting. In terms of the negative, copycat is the most well-known and documented. The copycat behavior is associated with stories that are reported in a way that invites maybe others to follow, and we think that encouraging people to help, to seek for help is also something that the media can do, and reporting about the life that the person has had is also important, and education through the reporting could also take place. The next one then is foster social-emotional life skills in young people. We just came up with the guidelines on mental health, promoting and preventing intervention for adolescents, and this is a recommendation that is universally delivered psychosocial interventions to all adolescents. We know that not everybody has the luck or the good luck of being in a family, in a context where they will learn these skills that will allow them to cope positively with the challenges of life. And so this intervention is something that should be promoted, and it can be done at school level. There are very interesting examples available in different countries. We do believe that early identification, assessment, management, and follow-up is important. We have these guidelines that have been developed several years ago and used in many countries with different key mental, neurological, substance use issues that could be managed by trained health personnel that is not specialized in mental health, but that nevertheless can learn some key issues to intervene. And suicide prevention is one component here. We think that again, although suicide is not only a health issue, we do believe that health sector has a responsibility here to intervene and to alert and to activate others as needed. So these interventions are based on core pillars that are very important for us. Situation analysis to identify the specifics of the problem in each context that we said before. We do think that, again, the multi-sectoral collaboration is key. We think that each other stakeholder has to be clearly identified and play an active role and be responsible for what they need to do. Awareness raising and advocacy is important because of stigma for the individual and for the community and for the society and for the health sector as well. So we need to do something in there. Capacity building for health staff, but also for any gatekeeper to be identified in the community that needs to be ready to know what to do when something is is ringing the bell. And there are interesting examples in different contexts of training taxi drivers or hairdressers, administrative staff. So we need to learn from there, and something that could take place in any setting if properly organized. Financing, clearly, because any of those initiatives and activities listed require specific resources. and evaluation. We talk about the importance of data, so surveillance, monitoring, and evaluation of every intervention that is put in place to make sure that it works. And if it doesn't work, we need to know and reshape it, redo it, implement it again, evaluate it again, as for any other initiative. So the main issue I want to say here is that we know what works. We know what has been successful in preventing suicide in countries, but we need to solve the bridge between that we know works and how to make it available at country level, how to make it happen. So supporting countries, in our case, with the needed actions to implement what we know works. Suicides are preventable, and suicide prevention is a public health issue. We just need to make sure that it's recognized as such and that we together fill the gaps for that, or build that bridge between what we know works and what is really happening at country levels. With all the complexities that are around the topic, suicides are preventable, is a public health issue, and there are a number of issues that could be done, take place in every corner of the world. So hopefully we will get there in the near future. Thank you very much.
Thank you very much, Dr. Castell. That was terrific. It was a terrific overview of the WHO and global perspective on suicide. Dr. Castell is still in the meeting with the Director General, so she cannot join us for the Q&A, but we're very fortunate. We have Aisha Malik with us, who is a technical advisor and a mental health expert for the World Health Organization. Aisha, welcome. Thank you for joining us.
Thank you. It's great to be here.
And I would encourage anybody in the audience who would like to send questions through the Q&A. Aisha will answer those questions. But maybe, Aisha, I will start, if I may, to lead off the question. And again, thank you for jumping in at the last minute for Dr. Castell. We really appreciate it. Can you comment a little bit from the global perspective, what you see as the future of suicide prevention cross-nationally? From where you sit, what are you seeing as the most promising areas that will evolve over time?
Thank you, Dr. Galea. And just to say again that Devora really does wish she could be here. I think going forward, what's been an area of our interest is that suicide prevention should take a comprehensive approach. And we've always suggested this to happen at the national level. And as you've seen, very few countries, in fact, have been able to take this approach. So what we're trying to do here with Live Life is think about the future of suicide prevention and recognize that action can take place both at the top-down level and at the bottom-up level as well. We're thinking that promoting the minimum approach to suicide prevention through these 4 effective interventions is the way to galvanize countries to have a sense of this is feasible and this is achievable. And for countries to recognize far more that this is truly a multi-sectoral effort. And you'll see that 3 out of those 4 interventions are very multi-sectoral, and only 1 really applies to health services in particular. So I think the direction going forward is to make suicide prevention seem feasible and think much more strongly at the multi-sectoral level and not only the health systems level.
Thank you. Let me take a question from Pasha Peshanov, and I'll broaden the question a little bit. Can you comment a little bit about social determinants of health and suicide and the availability of both evidence and data in that respect?
Yeah, no, good question. I think at WHO ourselves, we don't collect data on social determinants, but we look to what is available in the literature. We have a publication from some years ago, specifically looking at social determinants of mental health. And within that, 2 particular items were identified related to suicide. One was unemployment and one was alcohol. So with unemployment, I think there's examples given in Spain and in the UK, and in the UK in particular around 2008 with the economic crash, that there were more suicides than expected. So we know things like financial, economic loss are determinants. Alcohol use is a determinant. And there's evidence in place for violence and being part of a marginalized group, all of which contribute to increased vulnerability to suicide.
Thank you. Let me take a question, a similar question from both Katya Sharp and Nandini Agarwal. Can you comment about male-female differences in suicide? That the question correctly notes that it varies across countries. What is your thinking, WHO, thinking about underlying those differences at this point?
Yeah, it's an interesting question. So on the whole, the age standardized suicide rate for men is just under double worldwide than women. And I'm not sure if Devora mentioned this, but we know that in high income countries, that rate is almost 3 times higher in men than women, which is interesting. And then on the other side, in low and middle income countries, it's almost equal. So at no point would I probably ever say that female suicide rate is low. In fact, in 5 countries, 5 low and middle income countries, the rate is in fact higher. And why might this be the case that it's more equal in low and middle income countries? Well, women across the world face similar risks to their mental health and their well-being. And this may be exacerbated in low and middle income settings. And that brings in or starts to pull in a little bit more around the social determinants as well. Greater poverty, often working multiple jobs in hazardous conditions, experiences of violence, for example. So we might wage a guess that those are putting women in a more burdensome situation in those particular contexts. But on the whole, in every region, it is men who have the higher rate.
Thank you. A question from Pamela Morris. Can you point to countries or even cities or counties with the most promising progress in multi-sectoral approaches?
Yeah, that's a really good question. I think one of the examples that always comes to mind is Sri Lanka is a particular example. And I think Japan is another example. The 2 things that are common when it comes to multi-sectoral is, we all probably know it's not so easy to galvanize multi-sectoral efforts, to convince your agriculture department that suicide is important. What happened in these 2 countries was, at the one level, there was high level interest and involvement at the presidential levels or at the government levels in both cases, which was the first step towards something moving in the multi-sectoral department. For Sri Lanka in particular, they've had a tremendous success story working with the pesticide industry and with their agriculture sector in reducing in banning highly hazardous pesticides, contributing to a reduction in suicide rates. Japan have similarly seen many efforts taking place where they really have a focus on vulnerable populations and working with different departments, whether it's social work, pensions, etc., to address suicide.
Thank you. A totally different topic from Laura Santa Cruz. How can we work to improve responsible journalism, adhering to reporting guidelines related to suicide? I think it's interesting.
Yeah, really interesting question. I think we all probably need to do a better job of working with the media on this. There's been I've heard a couple of different innovations taking place in different countries. I know Lithuania, for example, have a dedicated service to monitoring the reports that come out in the media. And they've built a partnership and a collaboration with media outlets that gives them permission to be able to reach out and say, there's a difficulty here. Could you readdress the article? Could you rephrase the article? And a lot of that is done down to relationship building between the suicide prevention health center and the media in that country as well. So monitoring is one way. That can feel a little bit draconian, which is why we encourage something collaborative as well. Malaysia have examples of training that they deliver to media to explain, there is evidence that shows that the way we report can influence suicide rates, but it's for the better and for the worse. And really pulling in media to say, you have a role to play here in pointing people in the direction of help and reducing the distress that might be caused from sensationalized articles. And I think that's important now in these times more than ever.
Let me tie in sort of an addendum from Kyla Hui, who's asking, what's WHO's relationship look like with journalists? How does WHO work with journalists on trying to sort of change the conversations around issues like this?
Yeah, that's an interesting question. I think we ourselves have our own media team who have connections with journalists, and I think this is an interesting internal source of information to try to learn more from journalists themselves. Really, we're looking towards supporting countries in their work with their national bodies of journalism, and to do that, it's through producing recommendations on what both researchers and journalists can do to address the issue of reporting of suicide in the media.
Thank you. Let me go back to another question from Pasha Peshanov. The presentation mentioned about 40% of countries share their suicide data. What are strategies to connect the other 120 countries or so that are not sharing this data?
Yeah, it's interesting. So all countries report their civil and vital registration statistics to WHO, but from our side, the issue is really around data quality as well as access to the data. So only 80 countries have high quality data for suicide. I think the strategies that we really need in this circumstance is really capacity building around increasing good surveillance for self-harm and suicide in all countries. We've produced many technical tools on this. And I think that's one part of the issue. The other part of the issue is that this data isn't collected, it's underclassified, it's misdiagnosed, misattributed in terms of cause of death. This is a big issue going forward, and I think this again takes me back to capacity building and ensuring that countries are recording that data as accurately as possible, because otherwise estimates for the countries where there is low quality data are really are based predominantly on estimates.
A totally different question from Paola Painetti, which is, I think, a difficult and unanswerable question, but very interesting, which is how do we help countries prioritize what to act on in the realm of social determinants of mental health, recognizing that there are many social economic factors that matter? I'm just curious about your thoughts on that.
Yeah, it's a really interesting question. I think, and one that we've sort of inadvertently been reflecting on through a course of unrelated events this week. It stumps us. There's no doubt where suicide sits in terms of prominence of number of deaths and the impact on many people beyond the approximate 800,000 that we mentioned. And yet that doesn't garner the attention of countries. And you think, what more can be done? First of all, it's an issue of recognizing suicide as a priority, because you'd think if contexts have limited resources or time, and everybody has limited resources and time to pull themselves into prioritizing a particular health issue, that you'd go for the ones where there's the biggest impact. And that just isn't true for suicide. And it takes you back to stigma. Now, it might be that pathways to addressing suicide are through multi-sectoral discussions with the other ministries or the other departments that are relevant. So labour and welfare, agriculture, media, for example. One example that I always think of is the influence of the alcohol policies in the Russian Federation and the impact on mortality there. There are probably ways to have these conversations with these departments. I think part of what we're trying to explore with Live Life is really honing in on what are the essences of implementation that have been successful. What does it take to get that interest and that buy-in from the departments that are more responsible for these social determinants of health? It's a really interesting question. Anyone has perspectives on this, I think we'd certainly be very welcome to hear them.
Thank you. I'll ask one last question from Kelly Herco. Can you point to effective efforts to reduce stigma around suicide around the world?
Yeah, so really good question as well. Stigma reduction is crucial, and one of the ways this has been achieved is through methods of awareness raising. So I think one of the biggest pushes towards that is, of course, World Suicide Prevention Day as a particular example, World Mental Health Day as a particular example of really galvanizing global interest in the topic and in attempting to reduce the stigma, because ultimately this is very important. We know that stigma really gets in the way of help seeking, gets in the way of many other aspects, such as how suicide is recorded, as I said in the data, how interested countries and contexts are to take up that issue.
Thank you, Aisha. Really, really thank you for joining us. Please thank Dr. Castell for us as well for being with us, and thank you for everything you're doing on this for this question.
Appreciate it. Thank you so much, everyone, for your time and your really interesting questions. Happy to have joined.
Thank you very much. We're now going to move on to Dr. Josh Gordon. Dr. Gordon is the director of the National Institute of Mental Health. He has a long list of accolades and accomplishments, but I will not actually go through all that. You can read it all on the web, because I think you're really here to hear from Dr. Gordon himself. Dr. Gordon, thank you for joining us. The floor is yours.
It's my pleasure to be here, and let me just set up my screen for sharing. Hopefully you can all see my slides right now.
Yeah, we got it.
Yeah, I really appreciate that overview of the global situation. I think you're going to see a lot of parallels in what I have to tell you today, both in terms of the situation in the United States, which is not as ideal and going, as you saw from the graph, in the wrong direction compared to many places of the world, but also the approaches that we take to identifying and ameliorating risk for suicide. So I'm going to talk to you today about the National Institute of Mental Health Progress and Priorities in Suicide Prevention. The talk will engage four different parts. The first, rising rates, rising priority. The second, about risk identification. The third, about preventative interventions. And then the fourth, really about current trends of concern that make continuing in this vein challenging, but I think still hopeful. Let me just say at the outset, for those in the audience who don't know, that the National Institute of Mental Health is a part of the National Institutes of Health, and it is the primary federal agency responsible for funding mental illness research and the largest funder of mental health research throughout the world, really. Starting here, though, with our focus on suicide and trying to just articulate why we have this focus and why it's becoming ever more important. So this graph was sort of hinted at by one of the graphs that was shown in the prior talk. And this is a graph of age-adjusted suicide rates in the United States. You'll see in the dark blue triangles that males have higher rates overall than females in the light blue triangles, and their average sort of here in green. The salient piece of this graph really, though, is the continuing trend now for 20 years of increased rates of suicide in the US. There are specific elements of this which we could look at in more detail, but this is the justification that for declaring suicide to be a high priority. And as noted, of course, while suicide rates, at a rate of 10 to 15 per 100,000 individuals are a relatively small a contributor to death overall, the morbidity and mortality associated with the many suicide attempts for each completed suicide is notable. The comment before that was noted by the WHO that a national strategy for suicide prevention is really important is key. And I think in the United States, although that national strategy may not always be well articulated at the government level, we do actually have a national strategy for suicide prevention. It is a project of the National Action Alliance for Suicide Prevention, which is a partner with the NIMH. We partner with a number of different federal agencies as well as private organizations, both from advocacy and from industry, to formulate this national strategy, which includes, in reference to some of the comments that were brought up in the earlier talk, includes guidance for media on how to cover suicide. It includes guidance for NIMH and other research organizations with a national research strategy. And a key aspect of the National Action Alliance is to formulate a goal to reduce the suicide rate by 20% by 2025. That's a rather audacious goal, and it may be challenging for us to achieve. But there are a number of priorities that we bring at NIMH from a research perspective that are squarely aimed at the near-term effects that could help us reach that goal. We've articulated that in a number of different fora. I would point many of you here to an article that I co-wrote with two other NIMHers, my deputy Shelley Evan-Everly and Jane Pearson, who directs the suicide prevention research initiatives at NIMH that we published in JAMA Psychiatry this year. Briefly, these priorities are to develop and test decision-making tools for risk identification and for clinical decision-making, to engage in mechanistic research approaches to develop novel interventions, to study how to implement these novel interventions in a community-based enterprise. And importantly, a main goal of what we try to do is to leverage these research interventions through outreach and engagement to ensure that policymakers and industry enact the necessary evidence-based solutions. So I'm going to talk about two areas of research that I think are most germane to the topics of this symposium, that is, thinking about community-based preventative interventions and how to achieve them on a sort of a public health or population-based approach. And when one thinks about trying to reduce suicide, we need to think about identifying those at risk. That's the first part, and then developing and testing and using interventions to reduce that risk. One of the key important parts of identifying those at risk is first the data that was mentioned in the earlier period. And although certainly data on suicide deaths leaves something to be desired in the United States, particularly around timeliness, we do have a lot of information about the causes and associated factors leading to suicides in the United States. And this data that I'm showing here is from 2018, which is the last year that full data was available. And it's showing some overlapping categories of individuals who have died by suicide, 48,000 total in 2018. And you'll see about half of them die through firearms, and about half of them who die by suicide have accessed healthcare within 30 days of death. There are other relevant demographics here. The important point about these demographics is each of these circles can be seen as means by which we could influence these deaths and try to reduce them. For example, I'm not going to talk much about it today, but means restriction and safety around firearms is something that we could work on in the United States to try to reduce the number of suicides. I'm going to focus mostly on these two circles down here, folks who've been seen by healthcare organizations within 30 days or in an emergency room for any reason in the past year, thinking that if we can reach these really tens of thousands of individuals at risk for dying by suicide, and we can implement interventions that reduce that risk, we can make this dent, and we can reduce the rates of suicide overall in the US in the near term. So how do we do that? How do we prevent the most suicides in the shortest amount of time? Obviously, if we could implement lots of different approaches, we might reduce the rates overall, but we're talking about trying to do that approximately in the next 5 years. So the first step I've already elucidated, understanding when and where individuals, in this case, we're going to focus on accessing healthcare. And then identify within those situations, trying to find ways to identify individuals at risk, and then provide effective interventions to those individuals. And I'll point out again, 30% of people who die by suicide have accessed care within the previous 7 days, 50% within the previous 30 days, and 90% within the previous year. And emergency departments in particular may provide a unique opportunity to prevent suicides. Now, we've made some progress in risk identification here, one thing that's important to note is relatively simple methods of ascertaining risk can yield fruit in terms of identifying people at increased risk. This is now a study from over 7 years ago, looking across 84,000 responders to a standard assessment of psychiatric symptoms, PHQ-9, which includes one item 9, that asks about suicidal ideation. And what you can see is that for varying degrees of answering this question, you can identify people who are at significant increased risk of a suicide attempt or death by suicide over the subsequent year. So if we're thinking about people who access healthcare, and again, 90% have accessed healthcare in the year prior to a suicide attempt, we can think about simple ways of identifying those individuals who might be at risk, including giving them a PHQ-9. We at NIMH are not settled on just any one. We want to have a number of screeners and test them, and particularly we want screeners that will work in youths, because of course, youth suicide is an important component of this increased risk. We've developed a screener at the intramural program. Scientists there have developed an ASQ screener that has been proven to be useful in youths, both in primary care settings as well in psychiatric and in inpatient settings, and in emergency rooms. It's simple 5 questions, really 4 plus an extra one. And the key one here, and this is included in most of the screeners, is asking directly for all patients in a screening basis, whether they've tried to bed them having thoughts about killing themselves or ever tried killing themselves. How well can this work? I'm going to give you an example of the emergency room, although we have that attempt to examine how well does screening work in a variety of populations. This really landmark study led by Ed Boudreau, called the EdSafe study, sought to understand if we ask everyone in emergency rooms about their suicide risk, can we affect risk reduction? These here are, each colored line represents a different emergency room. They all started with treatment as usual, which is, it leaves it up to the clinician to decide whether or not to ask a given patient in the emergency room whether they've been having thoughts about killing themselves or harming themselves. And under that treatment as usual, you detected about 3% of individuals who come into ER in the United States will endorse symptoms of suicidal ideation. If instead of asking only the people you suspect, you then progress to the next phase of the study where everyone is instructed to ask, all the clinicians are instructed to ask everyone who comes in the door, regardless of reason, whether they've been having thoughts or harming themselves. Depending upon the individual ER, you get about 6% of people who come to the emergency room who will now endorse symptoms of suicidal ideation. And this study then went on to test an intervention. That same 6% were identified during the intervention phase. Now you might think, because we're asking everybody, that we're going to identify a group of people who are at lower risk of suicide than those who are only asked by clinicians who suspected that they might need help. And that's not the case. So here is the data from phase 1, treatment as usual, and phase 2, screening. And it's the y-axis here is the total suicide attempts per participant. And so you can read this as if you identify 100 people who are at risk, who you think might be at risk because they endorse suicidal ideation. In those 100 people, you will see 45 suicide attempts over the next year. It's a pretty high risk group. If you ask everybody instead of only the people you suspect, so that's in phase 2, you're asking everybody, you identify about 44 suicide attempts per 100 people who endorse suicidal ideation. So this remains a very high risk group. Now this phase 3 is the intervention. So you can ask, can you reduce the risk in this screened population through a relatively straightforward intervention of 3 phone calls home over the ensuing 6 months? And the answer is yes. You go from about 44 suicide attempts per 100 to about 30, and you move the needle in terms of the total number of individuals who judge to be at risk who will attempt suicide in the next year from about 25% to about 20%. So you can have modest but real effects on large numbers of individuals, in this case in a healthcare setting, by asking everybody and by increasing your interventions just ever so slightly in a very inexpensive way. And we've shown, NIMH data, fund investigators have shown this is cost effective. Now, you could say, since we're in a symposium about population-based effects, this is not truly population-based. This is a help-seeking population, even though it's a help-seeking for all causes in medicine. Other NIMH efforts have funded more population-based approaches, but still focused on the healthcare system as an access point. And we've done this in collaboration with the Army. I'm going to show you data from the veterans, and now we're continuing to replicate this in private healthcare settings in the United States. where we ask through a combination of demographic information, electronic health records, and some simple patient surveys, whether we can use a machine learning algorithm to identify tranches of individuals in a population who might be at higher risk and flag them for further follow-up. What you see by using these kinds of algorithms is you can pick and choose how big a slice of the population you want, but you're going to identify people who are at significantly increased risk of suicide. You can take the top 1/100%, that's a 140-fold increase in risk, or you can take, say, the top 1%, which represents about a 10-fold increase in risk compared to the general population. And you can devote, depending upon the resources you want from a population perspective, you can devote mental health resources at these high-risk tranches. And one other feature of this graph that I think is important to point out is that, especially for these highest risk groups, you're talking not about an unlimited period of time where they're at risk. You're talking about roughly on the order of months. So you can imagine that getting most of these people through with mental health care through a challenging period in their lives on the order of a few months, that you can substantially reduce their suicide risk. And you don't have to think of this as a lifetime proposition. So that is about risk identification. And just again, the summary, we can ask everybody. That's a useful way to do it. We can also deploy algorithms on a population basis to identify tranches of individuals at risk and get them the services that they might need. But of course, if we want to identify risk and we want to be able to reduce risk, we need interventions that will work. Now, I want to say at the outset, first and foremost, the data would suggest that we need to provide a lot of different approaches to try to reduce suicide risk. And I don't want to minimize the need to effectively treat underlying mental health conditions. We know that anywhere from 50 to 90% of individuals who die by suicide had evidence of a diagnosable mental health disorder. And then I also don't want to minimize the importance of social factors and et cetera that we can do. We know that, for example, social support, housing stability, food security, all these things play important roles in reducing suicide rates. I'm going to talk less about those interventions, though, and I'm going to talk more about interventions that we might target at these tranches of risk for the purposes of this talk, although I'm happy to talk in the Q&A about other evidence-based approaches for prevention, and I'll mention one population-based approach as well here. So again, what we're talking about is trying to use the healthcare system to identify individuals at risk and get those individuals into suitable preventative interventions. And one of the real actually roadblocks to convincing emergency room doctors, primary care practitioners, and other health professionals, convincing them to ask about suicide is the conclusion that there's nothing we can do to reduce risk, that, you know, knowing about suicide doesn't help me because I can't really do anything for my patients to save them. If they're going to die by suicide, they're going to die by suicide. And I would say overwhelmingly the data from years and years of NIMH-funded studies and studies funded throughout the world and by other organizations is that interventions for suicide actually do reduce risk. For example, if you screen for depression and treat them and follow up for that depression, you can reduce significant risk. Each of these are individual studies, and the meta-analysis of those studies shows a very strongly significant effect that favors the intervention. Similarly, interventions meant to help increase the linkage to follow-up care after identification of risk, they have very large effect sizes, reducing subsequent suicide attempts, and increasing that's down here, and then increasing the likelihood that people will access care in the middle. So there are interventions that we can do to reduce risk in those who we identify as being at risk. One of the things we're really interested in doing is trying to increase the evidence base and increase the number of different kinds of interventions that we can use, and also understand what works for specific interventions and how we might be able to improve upon existing interventions. And one of the major partners that we have in this regard is the Mental Health Research Network, which is funded by a number of sources, but most predominantly by the National Institute of Mental Health, that involves a conglomeration of 13 different health systems, each of which has their own research center. They get together to partner so that they can provide studies on a population of over 12.5 million people in 15 states. That's pretty demographically representative through healthcare management organizations. And they take advantage of harmonized electronic health records and harmonized protocols for research projects to be able to do research at scale that can help us improve upon existing interventions. And just to give you a sense of the kind of scale what we're talking about, I have on this graph 4 different major studies that have attempted to test interventions that have the potential to reduce suicide rates. An initial one by all of them funded by the NIMH in 2005, really a landmark study showing that cognitive behavioral therapy can reduce suicide rates. I had 120 people enrolled. Subsequently, the next year, a study that dialectical behavioral therapy could reduce suicide rates, an order of 100 people. The EdSafe study that I just mentioned involved over almost 1,400 participants, so a significant increase. Well, the study that the Mental Health Research Network is carrying out to understand how outreach can help with suicide prevention, and particularly using these algorithms that I've discussed, involves enrolling 19,000 subjects. So we're talking about much larger sample sizes, the ability to use those sample sizes to definitively demonstrate evidence-based solutions for the reduction of suicide rates, and also hopefully to us to be able to ascertain within a given intervention what are the factors of the intervention that help it work, what are the mechanisms by which it works, and that's really the pathway to improving upon those interventions and making them even more effective. And then finally, I'll mention, of course, that this SPOT trial is not just about larger sample size. These sample sizes are individuals enrolled and embedded within a healthcare system. These are community-based research studies that will offer community-based solutions, highly implementable solutions to reduce suicide rates. So we're really excited about collaborations like the MHRN that allow us to take these approaches. Well, what do we have coming down the pike that we think might make a difference in terms of novel interventions? And I want to mention, we have lots of things in the pike. I want to mention one in particular that's been in the news a lot, and that is the potential for rapid acting therapeutics for depression to reduce suicide risk. Many of you have seen these papers. This is one now, a couple of years back, that comes out of an industry academic collaboration looking at the effects of S-ketamine, a novel treatment-resistant depression agent that built off of the success with ketamine, showing reductions in depression acutely within 4 hours and 24 hours. There are also reductions in suicidality. Of course, this builds on the success of ketamine, which is a fast-acting agent, which reduces suicidality. And then also another new agent, brexanolone, the first treatment specifically for postpartum depression that reduces depression in postpartum depression within hours. There is some evidence from this and some early preliminary evidence that it may have efficacy against suicidality, either in the context of postpartum depression or not. We don't really know yet. And so the possibilities that these rapid acting antidepressants, which include ketamine and these two novel agents, may be useful to try to reduce suicide in the context of identified risk, particularly in acute risk. We're talking about individuals who might need to be hospitalized to prevent suicidal ideation and the like. And we want to understand, how do we use these agents in the real world settings to reduce suicidality and to save lives. And so we just funded a number of studies, something like 8 in all, that seek to understand the role of fast-acting antidepressants and of neurostimulation methods to see if, number one, will they reduce suicidal ideation in real-world settings, in outpatient emergency department, and then how do you actually effectively deliver them and safely deliver them? And so a lot of them are aimed at understanding whether these agents can serve as a bridge to patient follow-up, as opposed to inpatient hospitalization. And so we look forward to those results to understand how we use these fast-acting agents in the real world. I want to turn, before I move on from interventions, I want to focus now on one bona fide population-based approach. to reducing suicidality. And this is a study that's been going on for decades. It's a study that NIMH funded in its early days and is continuing to pay off. So a lot has been known about the use of early intervention, school-based and otherwise, in young children, and a lot of evidence suggests that these kinds of interventions can have broad-based protective effects against mental illness and substance use. And one of these interventions that has a lot of evidence behind it is the good behavior game, which is played by kids in their first and second grade, and as shown in this graph here, has long-term effects, not just what we already knew in terms of reductions in rates of mental illnesses and substance use, and by the way, also criminality. But here, what we can also see is reductions in suicide rates. So here's a control group in the blue dotted line, and in both females. This is women, so these are kids who played it in first and second grade, and we're now following them up in the late teen and early adult years. And you can see that those who had the good behavior game early in life have dramatically lower levels of suicidal ideation, whether they're female or male. Now, this study wasn't powered to detect things like suicide attempts or deaths by suicide, but a really surprising result is that a result of this game later on, more than 10 years later again, after they had the game, you see a reduction in all-cause mortality in these kids. Now, that could be from a number of different reasons, and they could not isolate out suicide in particular. But we can honestly say that these early population-based preventative interventions can have significant effects on suicidality and on all-cause mortality and other forms of morbidity. So we can say that these population-based solutions have clear evidence in support of their use. Just a couple of really quick notices. We're still interested in trying to explore how to use these approaches, whether they be risk identification and or intervention in real world settings. One of them is in recognition of the fact that not every emergency room that might want to do screening has the right personnel to provide follow-up. So we want to enhance suicide prevention in emergency rooms through the use of telehealth. And that application deadline is in October. We've already made, or we're planning to make at least one award in the next few months, and hopefully more. We also want to encourage novel thinking about how to engage suicide prevention efforts with practice-based solutions. And so we have a call out for research centers that will support the development, refinement, and testing of effective and scalable approaches to reduce suicide. These are all in the service of this pathway of, trying to address rising rates with risk identification and preventative interventions. And I think what hopefully you've seen is that we have a lot of these different avenues that we hope can and will be successful at reducing those rates in the near term. That said, I think there are some current trends of concern that we need to be paying attention to, and we need to figure out how to address. One of those areas of concern is with a specific subgroup. I mentioned, of course, that the rates in the US are rising overall over the last 20 years. That's true really across different demographic groups. But one of the groups that has been relatively protected in terms of suicide in the United States are African Americans, and actually other minorities with the exception of American Indians and Alaska Natives. But African Americans have had historically suicide rates about half that of white Americans. And although we don't understand that disparity, much like many other disparities, we definitely need more work in that area. One of the most disturbing trends that we've seen emerge really just over the last 4 or 5 years is that the rates of suicide amongst Black youth, I'm showing age 15 to 19, but it's really spans from age 9 to 19, have been skyrocketing in the last few years to the point where they are matching or even exceeding the rates of suicide of their white contemporaries. And this is a disturbing trend that we need to address. We have expressed a notice of interest to encourage applications that seek to understand and develop interventions to reduce this rise in rates, and I encourage people to check out that notice of interest. And I think that's one of several factors that we have to think about in current trends that may make it challenging for us to fully address the rising rates of suicide. Another one, of course, is the COVID pandemic. It's the reason why we are meeting virtually now instead of in person. And of course, we are concerned about the mental health effects of the pandemic. NIMH has put out a number of resources and also expressed an interest in understanding the mental health response to COVID-19 and developing mitigation measures for it. The Action Alliance that I mentioned before has also recognized that this poses a particular issue for suicide prevention and has developed materials on its website that its partners are advancing to try to address the mental health effects of COVID-19. The NIH as a whole has banded together to promote research in this area. One area that we are deeply involved in at the NIMH is helping to increase testing and awareness about COVID-19 in minority and other vulnerable communities. And that's backed up with implementation of technologies in those communities to enhance testing. And we're also interested in measuring and mitigating the social, behavioral, and economic effects. This is an initiative that we've already funded supplemental grants in this areas, and we're now evaluating grant applications, full grant applications in these areas to measure and intervene to reduce the social, behavioral, and economic effects of the COVID pandemic. Finally, there's another factor that we have to be aware of, and it's related to the first story that I mentioned about increasing suicide rates in Black youth. The reckoning with race that the United States has been undergoing and that many organizations in the US have been undergoing since the murder of George Floyd has required responses by institutions across the country, including, of course, NIMH, but also highlighted the need to understand and direct resources to our understanding towards reducing disparities in mental health outcomes. And although suicide has historically been an area where minority populations, again, with the exception of Native Americans and Alaska Indians, have been protected, there are lots and lots of mental health outcomes where minorities and other health disparity populations are doing much worse than the majority population, and then we need to understand why and develop interventions that adjust those disparities. Some of the things we've already done are here, but we are really interested in hearing from you about approaches to that. And I'll mention we have a request for information out. I think, yeah, here it's on the previous slide. I encourage you to visit that and give us your feedback about how we might foster innovative research in this area. With that, I'm going to leave you with the NIMH mission. We envision a world in which mental illnesses are prevented and cured, and we seek to transform the understanding and treatment of those illnesses through basic research. And I'm happy to take questions about anything I've talked about today, or really any other more general questions in the arena of suicide prevention. Thank you.
Thank you, Dr. Gordon. That was terrific. Let me start with one question from my part, and then I'll move on to the audience questions. One of the things that has always struck me as remarkable about suicide is the relative consistency of suicide death rate in the US, with an increase recently, as you pointed out, over the past century. When you look at mortality rate for motor vehicle accidents, for cancer, for heart disease, they've all been going down, but suicide has stayed the same with fluctuations. I was wondering if you can comment on that. How do you wrap your brain around that?
Yeah, so I think we first of all have to acknowledge that as a scientist, I wish I had better data or understanding of the problem, but I can certainly ascribe.
I'm asking as a scientist as well. So.
Yeah. But I think there are a few things that we need to understand about mental health research and mental health care that I think play a role in that. Number one is the incredible complexity of the organ that we're trying to study these disorders, right? So we are behind the rest of medicine in our functional understanding of how the brain works and how it goes awry, not only in mental illnesses, but also in neurologic illnesses. And so we see the same trend with Alzheimer's deaths. There's no increase, the decrease in that. If anything, there's an increase with deaths due to Parkinson's. Maybe we're going to see a turnaround with ALS now that we're starting to see a little bit better of understanding. But it's really hard to understand this organ, the brain, and so we have to acknowledge that CNS disorders in general have not made as much progress as disorders of other organs. Then I would add also that a major reason why we're seeing decreases in infectious disease isn't necessarily their greater understanding, but lots of advances in public health measures meant to decrease it. Sometimes those public health measures aren't followed nationwide, but that's a different story, not for today's symposium. And I think we don't have the same degree of consistency and of will to take on the issues of mental health and suicide. You know, the landmark, I think of it as a landmark CDC report of now almost 2 years ago, where they linked suicide deaths in the United States to social welfare supports, and specifically called out, you know, the need for employment, you know, the uncertainty of employment and the financial and food insecurity as contributors to suicide. These are, you know, struggles that the United States has not made significant inroads in, at least over the last 2 or 3 decades, although one could argue that, you know, over the century we probably have. So I think both from a science perspective in terms of understanding and treating the underlying disorders that often lead to suicide, and from a public policy perspective in terms of addressing the social determinants of suicide. And then one more thing, that is that mental health care. We have many effective evidence-based solutions for mental health. They are not uniformly applied, and although that's true for a lot of chronic illness, I think it's possible to argue that it's even more extreme in mental health compared to other chronic illnesses, that we don't do a good job in applying evidence-based solutions. And the reasons for that are also complex, including the dollars that we allocate to mental health, and the standards of training and quality control measures that we enforce upon the mental health community. So I think a lot of different reasons, but it comes down to a combination of science and policy.
Thank you. Let me build on your answer and take a question from Ken Thompson and a couple of other people. So you commented on the CDC report from a couple of years ago talking about essentially building on the deaths of despair argument, that particular social factors, economic factors, housing insecurity, food insecurity linked to suicide. How does that inform the work of NIMH? How does it inform your thinking about the NIMH portfolio and where we're headed?
Well, so there's 2 arguments here, and I think we're trying to hew a middle road. And in fact, we had a discussion about this issue, not in suicide prevention, but literally today with some of my colleagues. For a long time, the NIMH, and for that matter, other organizations within the NIH, have played down the need to understand social determinants of health. Let's make that very, very clear. And I think, especially because of the increased reckoning that we're all having around race, there's a lot of change now, I think, change which NIMH has been going through for a little bit longer, but which other institutes are also have been engaged in, around the recognition we need to do more for health disparities. And a lot of health disparity stuff is often, although not exclusively, related to these social determinants of health. On the one hand, and so what's the fight? The fight is, on the one hand, we are an organization that seeks to change things. We don't want to understand for understanding's sake, right? We are dedicated to improving healthcare. And we can look at a lot of social determinants of health, not all of them, but a lot of them, and say they're not really within our purview. We are not going to be able to, through our influence over the healthcare system, suddenly ensure that everyone who loses a job is going to have adequate food security and is not going to lose their home, even though we recognize that those social determinants of health are important, not just for mental health, but for other forms of health as well. So that's part of the tension. Part of the tension is we want to make sure that our research is aimed at problems that we within the healthcare industry writ large can help address. And then the opposite argument is that, you know, you're missing a large part of the variance that contributes to the development of illness and the successful prevention or treatment of those illnesses. And so I would say there's a tension between those 2 points of view. There's always been a tension between those 2 points of view. That tension is felt much more at NIMH than any other institute. Why? Because NIMH, when it was founded 50 years ago, was specifically founded as a public health enterprise. It was founded to train mental health professionals. It was founded to deliver and regulate mental health care of the United States as a response to the, you know, or to August states. And since then, that mission has been split off from NIMH, but that perspective has never been split off from NIMH. Right now, the mission of that lies within SAMHSA right now, and it has for decades. But the perspective of understanding the importance of these social determinants has not split off. And so I think we have that tension, and what we try to do is hew a line. And I hope you heard me say mechanistic approaches throughout. And I think what we're focused in is, even in the realm of social determinants, we want to understand mechanisms so that we can understand the leverage points that we can bring to bear. Okay, so we know that poverty affects mental health, and poverty affects suicide. What are the leverage points that we can do along that chain of events that leads from poverty to suicide that we can affect? Of course, we can argue to policymakers who have the power that we need to provide a better, financial a backbone for when people do lose their jobs. But that's not an effective argument from the realm that we play into. So we have to play into the places that we can. Let's shore up the ability for public mental health care systems to address mental health problems and school systems to build resilience. So those are where we probably can make the biggest contribution. So understanding the mechanisms that lead from social determinants to mental health problems and developing interventions that target those mechanisms, I think that's where our sweet spot is. That's sort of what we're coming to now as a result of the discussion between these two tensions.
Thank you. That's a really interesting answer. From Jawad Hussain, totally separate question. Can you just comment quickly on the data about the intersection of the widespread legalization of cannabis and suicide rates in the US?
I wish I could. I don't really know. Part of the reason we don't know is, as I mentioned, there's not good timeliness. So our latest suicide data at that level really comes from 2018. And though Colorado certainly had legalization prior to that, much of the legalization that's happened in other states has not followed on that. So I don't really, I have to say, excuse my ignorance on this one. And I don't really know. If you have information about it, I'm happy to hear it and to learn of it.
I think that seems like the right answer. I was actually curious if you knew better than I did. Let me ask you one last question, Dr. Gordon. Can you comment a little bit on the data on mental health and race is obviously really, really complex. It's really complicated, and in some respects, much harder to wrap one's brain around than it is around other things, let's say cardiovascular disease and neurological disease. And in the current moment, with so much attention on racial disparities, appropriately, I often find that in mental health, there is a lot less clarity about how those disparities fall. I was wondering if you can actually just comment on that and just help give the audience a frame for how you think about the issue of racial ethnic differences and the complexity of their intersection with mental health as well.
Yeah, so I think it is complex. I'm not being a cardiologist, I don't know if it's any simpler there or not, but it's certainly complex in mental health. I'll give you a couple of vignettes to illustrate the complexities, and I think, and I'll give you one that's sort of on the diagnosis side and one that's sort of on the treatment side. And neither of these address the social determinants, but I think, well, one of them might. So actually, one of the first things that I did as director 4 years ago when I took over is I went to a symposium I was really interested in about the use of these large healthcare EHR resources in mental health. And one of the talks was, a simple talk about understanding the prevalence of schizophrenia in this HMO that was reporting out their data. And they noticed that the rates of diagnosis of schizophrenia was twice as high in individuals who were Black than white in their population. And there was no understanding of why. Right? Is it because the people are more likely to give a diagnosis of schizophrenia to someone who's Black, or are they less likely to give them to white? You have to think about the population. These are all people who are employed. These are their children generally in their 18 to 20-year-old range they're bringing in. And, there might be reluctance to assign a diagnosis of schizophrenia. So maybe we're getting an underreporting of schizophrenia in white kids, or maybe we're getting an overreporting in Black kids because they are, prejudiced because of implicit bias or other bias on the part of the doctor. So we need to understand why some of these things happen. Maybe there's actually a biological difference in base rate of schizophrenia, although there's no evidence that from that, as you know, from any of the data around the world. So that's one of the things that I think about in mechanism. Let's talk about disparities in diagnosis. Why are those disparities happening? And, you know, down to the level of, are there actually differences in the load of symptoms in these two different groups? Are the symptoms different? Are they more obvious? Is there a bias if you were to obscure the race data? Will you be able to reduce that, et cetera? Why are there differences? And there's all these complexities that run into it. Maybe diagnosis is made a little more complex in psychiatry because of the subjective nature of diagnoses. We don't have lab tests, et cetera. So that's one piece of it. Another piece of it is now, as I said, I'm going to move over to the treatment side. We know that Latinx population are often, always, but often less likely to seek mental health care and less likely, and they have poorer outcomes when they do. And some of that we know is due to language. And so if we can get them the care in their primary language for Latinx people for whom their primary language is Hispanic, that we might be able to do a better job. But one really interesting study that NIMH-funded investigators have conducted in Southern California is to show that the place where people get mental health care really matters for Latinx communities. So in this study, it was a study of a school system, all comers, white, Hispanic, to a smaller extent Black, because just the population, but they randomized kids to getting mental health care in the school or in a community mental health center. And although as a group, the kids did better when mental health was delivered in the school, same intervention, same providers, but just delivered in one place versus another place. In the Hispanic population, it was the effect size was 2 to 3 times larger. So Latinx communities, it seems like one of the key factors to getting them to accept care, and that was the major thing, the kids stay in care. That was the outcomes were different, but the biggest reason for that was kids actually completed the courses of therapy in schools and not so in the mental health centers. That's a real important thing to think about, is where they're going to get their care. Now, we need to think about the mechanism for that. Is it about differences in transportation access? Is it about stigma associated with traveling to a mental health center or other healthcare center versus getting into the schools? Is it some other factors? We don't really know, but there we can think about tailoring interventions to specific communities to reduce disparities, and we can also think about mechanisms to understand how we do that even better. I hope that's a little bit of a flavor of the complexity.
No, that's a terrific answer. Thank you. Dr. Gordon, thank you so much. Thank you for an excellent presentation. Thank you for taking these questions. And thank you for everything you're doing every day. And I want to say thank you to our audience. Thank you for joining us for this conversation. Our third panel in this symposium is on October 15th at 4:30, and will be about solutions. We'll have 5 panelists who have implemented interventions, some of which actually Dr. Gordon referred to in his presentation, where we'll be able to talk now about, we started with the etiology, now we have the keynotes, and now we're going to move on to solutions and interventions. Everybody, thank you. Thank you. Stay well. Take care.
Thank you. Bye-bye.